Samsung Medical Center.
It's not good.
Professor Gwon.
Yeah,
Yeah,
I can hear
explain.
you. I can hear you. Okay, so good morning, everybody. Here at Samsung Medical Center, we prepared a very interesting case of a failed valve, sapien valve. So we would like to treat today. So my name is Hyeon-Cheol Gwon from Samsung Medical Center, and I actually begged him, Dr. Grube, to come over here to help me out to the place, especially the planning and the procedure. Here is the Dr. Choi, Seung-Hyuk Choi from Samsung Medical Center. There is Taekyu Park, our team. So Dr. Choi will introduce the case.
Yes, this patient was 81 years old male, and he suffered from dyspnea, near class 3, and his ECG is normal sinus rhythm. It's not atrial fibrillation. Past history, we have performed the TAVI in 14 months ago. So, but that final result is inadequate. So we prepare this case today. So at the time, first, before the TAVI procedure, echocardiography shown the mean gradient of 55 millimeter mercury, and out valve area is 0.9 centimeter square, and then mild to moderate AL. Next. And CT measurement shows us the annulus area is 665 millimeter square, and perimeter is 93 millimeter. Next. Peripheral angio with and CT angio revealed no stenosis. So, next. So we decide the valve size with a calculation from Dr. Gwon's originally he made it. So that is the 29 millimeter Edward Sapien 3 with 1 mil overfill. It's achieved just 0.6% of oversizing based on the area-based sizing. Okay, next.
Okay.
Yeah.
Okay, actual problem was that at the time was the large annulus size not indicated for core valve or LVR, but the sapien valve we measured at the 0% oversize, we can make it happen. So that's baseline angiography. You can see actually I started at a little bit higher. Marker was a little 1 to 2 millimeter higher, but in most of cases, actually it's working. But I didn't know that at the time, the larger sapien 3 valve have a larger shortening, especially it inflated with the overfill. So actually, you can see here that the marker is moving upward during implantation, and a lot of shortening, right? Next slide. So we found that the moderate to severe AR, and non-coronary cursive, actually the distal end of a valve did not touch the annulus. So we checked it with the wiring in the right side video. We tried to push the wire. It is very easily went down into the LV. Next. So we tried the second valve. But the marker was placed at the line of annulus. But during implantation, I found something wrong. The valve is not moving upward. Actually, the valve was stuck by the leaflet of the first valve. So too low implantation. And I hoped, anyway, the skirt of the both valve will cover the annulus. Next. But actually, it was not. PVL was not improved. Actually, right side is a TT, not TE. But the interesting finding was that there is a central AL in addition to PVL. That means that the second valve is pushing the leaflet of a first valve upward. So first valve leaflet is not closed. And moreover, if there is a AL, there is some gap between the first valve and second valve not covered by the sheath. So next. So the problem has been stable for 1 year, but the hemolytic anemia was a problem. So he treated with the erythropoietin and intermittent transfusion. So she admitted yesterday, and we found hemoglobin was just a 6. So we transfused 2 pints of RBC. The hemolytic anemia is the problem. Next. So, yeah, next, please. Oh, yeah, okay, next. So we don't know exactly what's the mechanism, undersizing of the valve, or possibly, next. Push the button. Slide, push the button, yeah, next, next. Maybe, previous one, yeah. Maybe there is a central area. It's the flow is coming into the first valve and coming out through the gap between the 2 valves. That's my hypothesis. Next. So we measured the height of the 2 overlapped valves. I found 35 millimeter. And the right side, left main side is 35.6. So there will be at least 1 millimeter gap between the 2 valve shafts, not covered. So, okay, it is quite rare complications. So, what do you think? How can we treat it?
Well, guys, I think that, hi, good morning, Dr. Gwon and Eberhard and the team. This is Eric Finkelstein. I think that this is one of the truly rare cases that are still really exciting in live cases before you even started the procedure. And I think that the discussion here is, as I said to Eberhard this morning, is probably even more important than the procedure itself, that we trust you all that you will do correctly. But I think that we should discuss 2 points. One, more than 2 points, but first of all, we have to discuss where do you want to implant the valve, and second, what size of valve do you want to choose, and maybe even what valve do you want to choose. I think that what valve is quite clear, but what is the size, where to implant it, and this is after you discussed, of course, the very important part of what is the mechanism of the AI. But I think that if we all agree that the mechanism is kind of a gap between the 2 valves, I think that we should open this for discussion of where to implant the valve and what size to implant here. What do you say, guys?
Yeah, ask me. Next slide.
Yeah.
Okay, still, we measured the endless parameter inside the valve is still 83. The parameter is 83. Next. It's just above the range of 29 millimeter evoludar. So maybe possibly can be indicated for the core valve 31. So I think that trying another sapien valve is not a good idea. What do you think?
No, we agree about this.
Yeah.
You know, Eric, we've discussed this in length yesterday. So I think we have to also talk a little bit about the situation here in Korea, because there was a question of should we pre-balloon it. You know, the largest balloon they have here, it's my understanding, is 25. So
Right.
that I don't think will do anything. The other thing is the Pro and the 34 are not available. So what we have is, in that size, we have the 29 millimeter evolute and the 31 millimeter. To be honest, you know, when I saw the angiogram this morning, you can see that the sapien, the tunnel of the sapien is a little bit off-centered. I don't know.
Today
Can they see
angio?
this? Can they see? Can
오늘
you see
angio
the
좀
angiogram?
올려주세요. Okay.
Yes.
Yeah, this is today's angio.
Yeah, so this is today's angio. You can see it's a little bit off-centered. And whether, you know, the leak is intra or central, central or intravalvular or perivalvular, there is a little bit of a puff on the other side. You can see on the left side, on the left, the valve's definitely too deep. and you know it doesn't cover the skirt doesn't cover it. So on the left side, on the non-coronary side, the first one was a little bit too high. The second one is a little bit too deep, but it shouldn't. You can see the most. At least it is my impression that you know the ventricle is filled substantially, and not just by a puff, but you know there's a broad reflux. So
So what you're saying is it probably a combination of intra and paravalvular leak.
That's what I believe.
Right, makes sense.
That's what I believe. And you know, there's always the question, Arik, why do you do something intravalvular if there's a paravalvular reflux?
Absolutely.
This is very reasonable, and I understand this discussion, but you know, our experience shows that somehow that can be resolved. So that is actually my hope, that at least that we can deal with the intravalvular, whatever that amount is, and in good part by the perivalvular, because there's either more pressure or the flux of the contrast, as he's shown in his diagram very nicely, the core valve should take care of that. So if we decide to take the core valve, I think it makes sense to do the 29, at least to start with the 29. Because you have the possibility to reposition it if something happens, or if you're not happy with the position in the first place. You don't want to make a mistake three times.
And the position
So-
and the position should be the upper point of the lower cell of the Edwards.
Well, that's what I thought, Arik. I think, you know, we cannot do much about the left side. So if we concentrate for a second on the non-coronary side, then I would take, and you know, metal, there's a lot of metal there, and it's not so easy to position it. But
No, I
I
totally
would-
agree with you. I totally agree with you, because there is misleading on the left coronary side where there is a miss of sinus, but the real annulus level is where you see the upper part of the jet.
Exactly.
So
Right.
yeah, that's where it is. Now, so if you look at this like this, so you see that the annulus is at the level of a little bit below the upper part of the second cell, all right?
Yeah.
So you
actually,
don't want to
there is
take
a-
chances, so the upper
Yeah.
part of the lower cell will be a perfect choice, like you said.
Actually, we have more stories about that this morning, making more complex. Next. So we try to push the wire. We used a straight wire, but it didn't come in. So because there is two wires or so. Next. Pigtail.
So, so while you're
Okay,
talking,
so
I
I
think
used the pigtail. The pigtail, it was went inside. So after pigtail was inside, we observed the echo TE. Now, I'd like to introduce Dr. Sungji Park in our hospital, the echo specialist, and he'll talk about the finding of the TE. It's a little bit different from what you think.
Yeah, this
Park?
is the long axis view. You
Echo-
can,
echo
yeah.
change.
에코,
좋은 과정 보여요.
에코 스크린 올려주시고요. 그 다음에
크게 메인으로.
영상은
Yeah,
세컨. 박성지 쌤 좀 잡아주세요.
This is the echo long axis view. You can see the severe paravalvular aortic regurgitation, and first moving is the previous first valve, and the second moving is the previous inserted second valve. And short axis view shows the severe paravalvular regurgitation, as you can see, and the other view also shows the severe paravalvular regurgitation. And we got some central air,
카메라 2번으로 잡아주세요.
some central air and first and in the second valve, but is that the amount of the central air was decreased after wire insertion.
So problem is that the TTE and TEE yesterday demonstrated a very significant central AR. And today I tried to push the wire and the pigtail into the LV. Afterwards, the central AR is, we cannot see very clearly because of the limitation of TE, I don't know. But so we checked the angio after
Final
wiring.
please.
Final 좀 보세요. After the pigtail inside. Angio again. What do you think? It's a little bit decreased. A little bit decreased.
The contrast injection is not optimal. Dr. Gwon and Dr.
Yeah.
Abahar, this is Ramesh Dagubati. So I think, in my opinion, this is a paravalvular leak because even the anemia is significant. So I would actually try to balloon it. As you said, there's no larger balloon, but how about maybe using two 14 or two 18 millimeter balloons and doing a double balloon valvuloplasty first to try to see if we can seal the paravalvular leak. If not, the option number 2 is why not try to do a paravalvular leak closure, and before we go on embarking onto a third intravalvular core valve.
Yeah, so that is reasonable. Now, you know, let me tell you, I would still go ahead with the core valve because the ballooning situation you really don't know. You don't take care of the intravalvular problem, and then you don't know whether you'll be able to expand the sapien further. You might, but you're not sure. And on the closure side, at least it seems to me that the paravalvular leak, at least is not a small one. It's a little, you know, half moon size, and that's probably a little bit more difficult. I would still prefer. I mean, if it was my patient, I would still go ahead with the third valve, and see, you know, what we can do. Then at least the intravalvular part is taken care of, and many times, as you know, the paravalvular part will be taken care of also. I would take that chance instead of a double balloon technique and post-dilate it with two balloons.
My assumption is that maybe the echo is not very accurate to identify the location of the AL. There is some jet is very eccentric, and we don't know. And still, by the calculation of the height of a valve, still, I believe there is some gap between two valves. Mm-hmm. So that is the cause of the AL. So this patient, actually, our target, clinical target is the hemolytic anemia. That is kind of rare in the patient with the PVL. Mm-hmm. So I still believe the central AL and central AL-driven PVL
It is not
is
actually
a major cause.
And Dr. Gwon, I think actually the presence of hemolytic anemia suggests that in this patient has significant paravalvular leak rather than a central AI, because central AI should not be causing hemolytic anemia. And even in your iotogram after with the Confida or Safari wire, we could still see on the lateral aspect there is a jet that is paravalvular leak filling the left ventricle.
I mean, central AL is not pure central AL. Central AL and leading to a paravalvular leak through the struts of the between the gap. That's
Dr. Gwon,
very
I am-
complex.
No,
Doctor.
there is no doubt
Yeah.
that there is a PVL, and a significant one. Now, I totally agree with Eberhard in this case. Look, just ignore the two valves. Look at each one of them just as if it is the only one. The upper one is definitely too upper that will cause paravalvular leak, right? Now, the lower one is definitely, have a look at the upper part of it. Ignore the upper big cells that are nothing, you know.
Yeah,
And
right.
it is too low, so it can easily cause a paravalvular leak. Now, tell me, when in the last time you have seen a sapien in place in a not too heavily calcified valve, I don't see here extremely heavily calcified valve that caused such a leak. So why do you look for a rare thing when you have the picture in front of you? Maybe I'm wrong, but it looks like so obvious. One is too high, one is too low. There is a gap between them, and you can try and solve it easily with not too much risk and too much manipulation with a simple implantation of Evolute. The only question that we discussed yesterday is whether to take a 29 or a 31. If they would have here a 34, we have no question. But since 31 is a different animal, so-called, I think that they should start with a 29, and then we shall see.
I think what you said, I think is very important, and that's what he has shown in his pictures. There's a gap between the two that are unprotected by any sealing. So what happens is, here you inject, and you inject on top of the first one, and the blood can go in between the two valves outside, and nobody can tell me whether it's intra or para. You know, I would take the easier part, and you know, remember that's just a 229, so we have a good opening area with a good opening area, supravalvular with core valve. So I'm not concerned about the third valve constricting the opening area or the flow. So I would take the easier part first, because everything that's being said is still open after the implant. And if we can get rid of a good part of this, then I think we have achieved something.
So there is a
Dr. Gwon,
lot of possibilities, but still the hemolytic anemia is the major target of the valve, and hopefully another valve will resolve the hemolytic anemia, the need for transfusion. Okay, so
Dr. Gwon, I am
anyway,
Jung Min An.
Yeah.
I have some confusion. So you mentioned that the mechanism of paravalvular AR is central AR plus paravalvular AR,
Yeah.
but I have a little bit different idea. So I think.
So can I ask you for something? This is an important part of the procedure now, and I think Dr. Gwon has to concentrate exactly on the positioning. We can discuss afterwards all the questions.
Okay.
But now I
Then
think
we
it
have
is
some
very
middle
good if you would give him and
there
allow
is
him
no
to
significant resistance
position it,
here.
and then we
Yeah.
can discuss
Working
afterwards.
position. Okay.
Very good.
Okay. There's no resistance. Okay. Yeah. Now we start very slowly.
Can you magnify one more?
좀 하나 더. PP 좀.
Because you know now it's important that on the left, on the non-coronary side, that he can deploy the core valve at that time correctly. Because on the left side you can't influence.
Yeah.
Well,
little
put it
bit.
up.
We are going up.
Slowly.
Yeah. We need to going up. No.
Can you do a
Here.
puff?
Okay.
Can you do a puff with the pigtail?
Yeah. Puff. Yeah.
Do a little bit deeper. Yeah, that's
Yeah.
perfect.
Okay. Okay. Targeting the top of the first cell of the second valve. Okay. Why a little bit higher?
Yeah.
You need to be a little bit higher.
Yeah.
Okay. Okay. Go slowly.
This is one of those cases that you are convincing yourself not to be greedy,
Yeah.
not to go exactly where you
Okay.
want to be, but just satisfactory.
All right.
Very good, Dr. Gwon.
Very
Right
good.
now,
Yeah.
it's a perfect
I'm
place.
maintaining at the point. Okay.
Keep going. That's good.
Okay.
So now he has the valve has contact now.
This is beautiful.
You can go.
Okay.
You can go. Faster.
Oops, he jumped.
Oh,
Yeah.
Yeah.
Reposition.
He popped up.
question. And I thought this was a top down. Maybe we need to target a little bit lower than the.
No. What
just-
you try to do is to pull it up. Don't worry about it.
Yeah,
Once
yeah.
the contact is
Yeah.
there,
Yeah.
then keep it there and don't do anything. Just let the valve get in touch. That's
You can,
very good.
you can
To
use
that-
rapid
to that-
pacing while you are implanting, don't you think?
No, I think so.
Heart
Okay.
rate is very, heart rate is
Okay.
a very is alternative. So some pacing is
Yeah.
more comfortable.
Bye-bye. 조금 더 내려야겠다, 그지? Okay. No. Okay. Layover. Okay, bye-bye. Slowly. Too deep. I wonder if the inside of valve is a little bit slippery, but it's made of a metal frame with a cusp. Yeah. Okay. 조금 더
조금 낮아요.
I can see
Keep it
the
there.
left
Yeah,
side.
because, you know,
it's very difficult to
It's
see.
okay.
Yeah,
just-
move the
Yeah.
projector
Okay,
a little
just
bit.
push it,
because-
not to jump.
Okay.
점. 점부터.
So can you
Yeah.
move the projector? Get the catheter, get the valve free of the other one. So you're overlaying the delivery
maybe
catheter.
I need to pull out and get some. 이거 좀 뽑아줘. I think it's a little bit slippery inside. There's no hard pressure inside.
Can you change this, the projection a little bit?
A little bit. The catheter.
Yeah. So
The
because it's
LAO?
overlying.
LAO? No.
Okay, that's better.
Okay. That's better. Okay, try again. Okay. 완전히 들어갔나? 둘 다 낀 거 아닌가? 잠깐만 뽑고 조금 더 닫아봐.
맥시멈.
Maximum. There is some gap. Yeah. Okay, I pull the wire
Very good.
and push and lay over a little bit. Okay. There's too many metals, too
Yeah,
many
it's a lot
lines
of
here,
metal, yeah.
so it's very difficult to find out.
That's okay. That's good.
Okay. It's moving by the pulse. It's a little bit lower than before.
Go ahead.
Yeah. Still, we have some room because the sheath length
Now I do.
height is about 14.
So
It's
push a little bit.
I push a little bit. I'm pushing
Okay,
it.
now,
I'm
keep
pushing
going,
it.
keep going.
I'm pushing it.
Keep going.
It's too high.
Pushing it.
This is too high.
Pushing it.
팔.
Keep going. Keep
Oh,
going.
we
Keep
don't
going.
know. Actually,
Stop.
we don't know. Okay, stop here.
How's the pressure? Do we have to pace?
Phil?
페이스.
No.
Good.
No, it's too high.
아, just
What do you
It's too
guys
high.
think?
Actually, there is some more lines. It's just difficult to see.
I know, that's what I told you.
Yeah. Actually,
There are 3 layers
I
of
don't
metal
know.
now.
Yeah.
Eberhard,
Yep.
I think it might be okay, but there is a very good chance that it is too high. I would rather get another chance, and if you are asking for my opinion, the main problem is that
라인이 더 있어.
the rhythm is irregular, and whenever he's
you-
giving a beat, it
you
pushes
pull the
the wire,
picture
the valve up.
Inject it
So I
in.
would rather start the implantation, and after the beginning, I would give a rapid pacing,
Test.
and this will stabilize it. But right now, you are a little bit too high. You are on the 0 or even less.
I don't think so, actually.
play. 조정하고 play. Still, the core valve metal is at the top line of the first cell. It's very difficult to see that the wire
Yeah,
frame
you
is
can't-
thinner.
네.
I think
I-
you are, on what we can see here, Eric, is on the non-coronary side, we are at 3. So this is really where we want it to be.
Can
I think the depth is very nice. So could you
I
check
think
the
that you
outer
are
rim?
right. On the left coronary, on the left coronary, you are exactly where you want it to be.
Maybe you can
Like-
try the lower positioning.
slightly low.
So actually, the valve was positioned at the target we intended at the top of the first cell. It's very difficult to see because the frame is thinner. Core valve frame is thinner, but still very carefully you see that it's touching the. Maybe we better to be secure to lower implantation. What do you think?
I think that if you release it like this, you are going to have a combination of sealing on the left side with the core valve and on the right side with the head ones.
Dr. Gwon,
I don't think so.
Dr. Gwon,
Yeah.
is there the echocardiographist? Can you show us
echo.
that the TE and then
But
is there any?
Dr. Gwon,
Yeah.
I mean, you are so confident and you are implanting it so easily and so confidently. Why would you like to take a chance whether it's in place or not, instead of retrieve it once more, and do it in
Yeah.
a way that you will be sure.
Yeah,
I mean,
actually,
why
I
do you
like
want
to
to take
try.
a chance?
Yeah.
It's
Yeah.
got no price.
Yeah, I try a little bit lower,
4 mm.
Okay.
a little bit lower. Yeah, we capture it a little bit lower.
Don't you agree with me, guys?
Yeah. T 좀 채워줘 보세요.
You said
Actually,
I
T
completely agree with you.
is
Take
not
another-
so
this
helpful at this moment.
especially this is the third
I
valve.
mean, it could be,
Right,
no,
right.
but it could be okay, but
Yeah,
why do you want to take a chance?
yeah.
It's
I
not
will
something
I will
risky.
Right.
try the last
That's the
implantation.
advantage of core valve that you
Yeah.
can attempt
Dr.
multiple
Kwon?
Right.
times.
Yeah.
It's such a
I
forgiving
I
valve.
cannot do it forever. 좀 더
maximum.
저게 밸브가 좀
Dr. Gwon, since you have like 2 layers of stent, it's very difficult to locate the
Right.
lower part of the
Right.
core valve. So wouldn't that be better to have the rapid pacing while you implant the core valve?
사람들과
Absolutely. We all agree that I think rapid pacing as you are going to deploy it will stabilize the valve.
Chest is not in place. You're right. Okay. Okay. So rapid pacing.
Yeah, I would
not
probably,
now.
in this case, I would rapid
one-
pace also now because
120,
the valve is really moving.
100,
Yeah. 150. 100.
yeah,
110.
100 pacing.
100.
100km pacing start. Okay, we started pacing by 100. Okay. A little bit low. Yeah, it is a little bit too low, but
Okay.
still
Okay.
I need
That's
to
fine.
stay
That's fine.
inside
Yeah.
of the second valve. It's okay.
That's fine.
Okay. A little bit low.
Yeah. How,
No, no, no.
This is fine.
Too low?
It's fine, fine,
It's
fine,
fine. It's fine. This is fine. It's I'll try
Go
to.
ahead, go ahead, go ahead.
See, the pacing actually stopped at that time, exactly, when it jumped.
Okay, pacing off. It's popped up. 저장하고 플레이 좀
It
해봐요.
didn't-
마지막을 잘 모르겠는데.
Did it pop out?
플레이.
봐봐. 아니, 지금 있는 상태를 보자니까요.
Please see the
그게
blood pressure.
마지막에.
Blood pressure is
Take care of the
Pressure
pressure.
low. Yeah.
프레셔.
BP 좀 봐주세요.
See, this is, I mean,
다이지.
보여주세요.
the enemy,
아니 마지막 튀어나온 걸 좀
the enemy
보려고.
of the good is better. Now it's up, yeah.
네, 퍽. 네.
popped out 됐지.
네,
네. It's kind of slippery. Still, I'm
Yeah, but
pushing
you
it.
were, now we're talking about millimeters here. And it's not like a regular deployment. It is, you had 3 pop-outs now.
Please see the blood pressure.
It's
Blood
way
pressure is
too
very
hard.
low.
Even higher than the
SBP
first
is
So you have to
56.
reposition.
56 SBP.
아 그러니까 알고 있어요. 혈액 좀
You have
혈액 좀 봐달라고.
you have to move.
Yeah. Remove it.
Maybe you're including the coronary.
Go ahead, go ahead.
뽑아.
No,
Recapture.
recapture.
Recapture. Capture.
어,
Yeah. Blood pressure going. 야, 대기 해주세요.
All the way.
Yeah.
Okay.
Okay.
No, no.
자,
In a situation like that, with 3 pop-outs,
yeah.
I don't tell me that you want to have it a little bit 1 millimeter higher or 1 millimeter lower.
Yeah.
You would be happy if you have it seated where, just about you want to have it. And now we have, we let the patient recover a little bit, and I think the pacing is good, and then, you keep the valve down there where you had it. There's always, as I said, there's always a good chance to make it better, but there's always a chance to make it worse.
Yeah.
You didn't make it
So,
worse yet. Eberhard.
Well,
it's-
I mean, you had 3 pop-outs,
So
and,
what?
the patient is hemodynamically stable,
Yeah.
but you don't want to do this forever here.
Yeah.
No.
So what do you think we have to stop here?
No.
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 You do
That's
the,
right.
you do the one that you did in the first place, and
Yeah.
and deploy the valve.
Yeah.
Now see, now you have the overshoot of the pressure because she
Yeah.
gave medication,
Right.
and that's not going to be easier. So let's go again.
오케이.
잠깐만요. 혈압이 너무 높아.
Would you pace
아니,
at a higher pace?
페이싱 해봐요. 페이싱 120, 120, 120, 페이싱 120, 50, 150, 네, 150.
You know, when you want to have the when the valve
Okay, stop.
when the valve expands, you want to do it when it like this. You want to do
Fast,
faster
okay.
because you want to have the contact.
Okay.
Yeah.
And then once you have it, the contact can push.
Yeah.
So you
Maybe
Okay.
the
pop out.
blood pressure too high.
Yeah, that's always the
Yeah,
case.
yeah, right. How about 180 pacing?
Yeah.
Yeah, 180. 180. Start. Yeah. Pacing. Blood pressure.
No.
Okay, stop.
No.
So 150 or 60 around there. We can control the blood pressure around just below the 100. Okay,
Dr.
how about
Gwon.
that?
To do
Dr. Gwon,
Yeah.
are you planning to do the implantation with true rapid pacing now?
Yeah, regardless of the heart rate, I just control the blood pressure just below the 100. That's what I mean.
But I think that's a very good idea. You know, why not do rapid pacing at 180 and deploy the valve?
So maybe
I mean, not
150
completely.
is good for this patient. Okay, we can adjust the heart rate, the pacing rate, but when you look
see,
at
this is when you
yeah. Okay, try again. So this
다시 들어갑니다. 박수
네,
교수님.
들어갑니다. 오케이. 페이싱 150, 150. Okay, pressure is around 90. Okay,
Slowly.
yeah, slowly. A little bit higher. Higher.
Okay, 됐습니다.
Getting higher.
Going.
So I push a little bit. Yeah, okay, go ahead.
keep going.
Yeah,
going.
too low.
Push.
Yeah,
Don't worry
too
about
low,
it.
too low. Yeah,
No,
too low is okay,
Keep
but
going. Keep going.
keep going, keep
Okay.
going. Okay,
Okay.
keep going. Pace off. Yeah, it's 1 millimeter beneath the first valve.
It will be beautiful. We'll see.
I'm not sure. The sheath length of the core valve is 14. In our calculation, actually, we touch the about 11 millimeter will cover gap, but we don't know.
Can we do a pacing with 70 or something like this?
70, pacing 70.
I think
Okay,
the diastolic
fluoro-
pressure is getting better than before.
Yeah.
So
Will you give an injection
No.
or an echo?
에코.
Echo, I'm not sure. Okay, echo. pacing 지금 한 90,
70하고 있어요.
그럴까요?
딱 맞습니다.
Okay.
Yeah,
Yeah,
the
it's
long
a-
XVU looks little bit looks decreased of paravalvular AR, but I cannot show the central AR.
괜찮으세요?
Short axis, please.
Yes, wait a moment.
Actually, half of the circle, we could see the paravalvular
The
leak
position is just above the
beneath
second valve.
beneath the second valve.
Do you have a stick? Something like
Stick.
no, something like something like that. Do you need this still?
Looks like
So
our
where-
PVL
where
is
do you-
a
where
little
do you
bit
see the valve?
decreased.
Yeah. PVL
What do you
amount was decreased.
Yeah, PVL is decreased.
There.
Yeah.
Yeah. So that's
There
exactly
it
the
is.
height of
10
the
o'clock.
previous one.
Right, yeah. It just overlapped.
Just overlaps.
Yeah.
You know,
Some PVL in 11 o'clock, when you
Yeah.
see the echo.
Yeah,
PVL at
Yeah.
11
but
o'clock
right
is
now,
still there.
but right now you have to deploy.
Yes,
Right.
sure.
So the question is another try or deploy it?
Really?
No, I would deploy it. I would have done it in the first
Yeah, I
place,
would
but-
deploy it, so I don't like to try once more. Okay, deploy it.
Can you point it?
뒤 좀 빼주세요, 뒤.
합니다. 천천히
Yeah.
하겠습니다.
Not the perfect place we are intended first, but
Yep.
I think it's okay.
Okay, that's it.
Okay. 디바이스 좀 빼주고 와이어 넣고 와이어. Okay.
Can you exchange to a picture?
Yeah. This one or you have the picture?
No,
Ah, this one. Okay. Okay. 이것도
Why don't you
붙이고
take it out? That's good.
붙이고.
와이어
Okay. Wire, keep wire, wire. Okay, yeah. I'm removing the valves.
What do you think, Eberhard?
I don't know. I think we'll see. I will see how it is.
So you are doing this procedure every day, right?
Yeah. So,
I think that you are about 5 millimeter lower than you
So now
wanted to be,
Yeah,
but
yeah,
still,
Yeah.
I'm almost positive that it will be okay.
어디 갔지? Okay.
숨을 좀 빼주세요.
and I'll put the picture
Okay.
there. The other picture, I mean.
Yeah. Let me connect the pressure here.
Can you pull the probe?
Yes.
Okay. Good.
Inside the valve.
No, higher.
No, higher?
There. Yeah, because you don't want to. You want to inject against a little bit deeper.
Yeah.
You don't want to inject against the lesion. So okay. There. Okay.
Okay. Right? Good. Flush it. 괜찮아? 이것도 pressure. Air index.
Professor
May-
Gwon.
yeah, I failed to mention, but the air index before the procedure was 0.33.
바꿔야 돼.
적지 말고. 네. You want an injection, right? Yeah. So yeah,
오케이.
here. Okay, inject. Yeah, 똑같이. 준비? Ready?
No, but
Injection.
take the picture a little bit higher
Ready?
because it's going to inject on the valve itself.
Yeah. Okay. Oh, okay. Sorry. Yes. I am too excited. Okay. Okay, run here. Sure. Yeah.
Okay. So
Yeah. Let's see.
it's good.
Not eliminated, but decreased.
No. It's much better.
Much better. Yeah. Not
This is-
eliminated at all, but
No, this is much better because
Yeah.
now what you can see is it's still reflux, but it's being pushed out with the next beat. So by definition, it's
It's
better.
definitely
How about
less.
T?
Yeah.
How about T?
key.
Yeah,
Yeah.
T show
Put the
that.
echo screen 올려주세요. Put the
Would
echo
you,
screen.
would you make a
Okay.
post-dilatation now, Eberhard, or one?
With 25, with a
Yeah.
25 balloon.
The largest balloon in Korea is 25, so that's the limitation.
Oh,
As you can see here is the long axis view show the originate paravalvular area from the RCC area, but is the amount of the PBL was decreased after the valve implantation. And short axis view show the here is the 6 o'clock. You can see the paravalvular regurgitation.
The central layer, I
The
think.
central ear. Yeah.
6 o'clock central.
Oh, yeah, is the wire.
Yeah, wire.
Yeah, wire.
Pigtail.
And in this view, I can't see any paravalvular
I don't
layers
either.
there.
Yeah. Yeah, definitely it was decreased.
Yeah,
So,
of course it is
yeah.
decreased.
Our hypothesis worked. Anyway, we
Professor
didn't
Gwon
eliminate it, but
Dr. Grube,
Yeah.
we are very happy. We are good
Yeah,
position
I'm happy
and
too.
thank you.
Well, I
Yeah,
think
good
you know,
result.
and you could see when you in a situation like that, you know, the enemy of, as I
Yeah.
said.
he says it's time to leave.
Yeah, no,
He'd
but
like to leave us.
yeah, no, but I think it's good. I think we achieved the goal, and you could see the difficulties in positioning it.
Right.
And I think we didn't want to have another pop out.
Right.
And I think given those circumstances, I think you know it's quite nice, and I think you know you could achieve what you wanted to achieve. And I think it was a difficult case, and the discussions were vivid. So,
Okay.
as far as I'm concerned, I would
Yeah.
leave it.
Thank you very much.
Thank you very much
Thank you very much.
for
Thank you very much, everyone.
We are
amazing
moving to
case,
Seoul
very
National
challenging
University.
and very, very educational. Thank you all.
We are moving to Seoul National University. They are already prepared.